Hello, everyone. Today I'm going to speak about the progress in my PhD studies, heart rate variability and depression, patterns across health and disease. My name is Shir Galin. I'm a psychologist and a first-year PhD student. My vision is reducing mortality and improving lives through psychology, and my mission is integrating psychological dimensions into everyday healthcare and policy. The past fall, I've started 2 projects. On both of them, I'm going to speak up next. So the first project is investigating the accuracy in predicting depression through heart rate variability in non-depressed population, which is a systematic review and meta-analysis. So depression is a very big problem because it affects over 280 million people worldwide and has substantial health and mortality risks. As you can see on the top right corner of this slide, suicide is the first cause of death in the ages between 15 and 29. And major depression actually increases suicide risk by 20-fold. And approximately 700,000 people die by suicide annually. However, we have a striking gap because over 50% of suicide victims had no psychiatric diagnosis beforehand, so we can't help them. And that is because we have a problem. As psychologists, we have no biomarker for diagnosing depression, so we rely only on subjective reports. We ask our patients how they are. What is your mood? Okay? And that means that I have no early detection strategy for depression. And that has dire consequences because nearly 2/3 of depressed patients are never diagnosed. And those who are diagnosed suffer from 2 to 8 years delay in diagnosis. So, which means that if we can diagnose them early, we can save lives. However, we do know that heart rate variability, which is a cardiac measure, is lower in individuals with depression. So our aim is to investigate the relationship between heart rate variability and depression to enhance early detection and prevention strategies. So our clinical question was, does lower heart rate variability precede depression in a non-depressed population? We're using the PFO model. The P for the population is non-depressed, the factor is HRV, and the outcome is development of depression. The hypothesis is individuals with lower HRV have increased risks of developing depression. And answering this question have clinical implications because using HRV as a biomarker for screening, it might enable us early prediction of depression. So we've done the systematic search with 2 domains, the first for HRV and the second for depression in 4 different databases. And that yielded approximately 18,000 results. And after screening them, we ended up with 176 eligible papers. We have just finished the ROB assessment, and parallelly, we've started reading the manuscript. We already finished the introduction, the methods, and the systematic review. Let's proceed to our results. Here, in these forest plots, you can see the correlation of adults' baseline RMSSD with future depression scores. RMSSD is root mean square of successive differences between heartbeats, and in simple language, it means the variance in the heart rate. And RMSSD is the most widely used HRV measure. It's incorporated in most of the smartwatches we have, and it captures the parasympathetic nervous system work under stress. So here, based on 5 papers and approximately 400 patients, you can see that the pooled R coefficient is 0.22, which means that lower HRV is correlated to higher future depression. This is both statistically and clinically relevant. And it stays significant, although the heterogeneity is quite high, and it's due to different follow-up periods between a few months to more than 10 years in these papers, and also different comorbidities of the sample. Interestingly enough, we got the same results with different HRV measures. So here you can see that high-frequency HRV, low-frequency HRV, and very low-frequency HRV all have the same results, while we see that low HRV is correlated to higher depression in the future. However, we weren't just interested in the correlation between HRV and future depression. We were more interested in the prediction ability of the HRV. So we continued to do some analysis, and we found out that it's very hard to do because of huge heterogeneity between the papers. So we decided to do a systematic review that actually found out that the direct prediction of future depression by HRV is weak or inconsistent across studies. However, HRV is like a secret ingredient in a prediction model. It's a moderator. And the predictive value of HRV emerges in interaction with context, like a parenting style, trauma, or gender. HRV actually acted as a shock absorber of the nervous system in preventing future depression, but not linearly. So too little or too much of a variance in the HRV can both increase depression risks. And if we want to see the pattern that we found out in a systematic review, we see that HRV in future depression risk has a U-shaped context-dependent pattern. So when there is high adversity, like harsh parenting style, or chronic illness, and chronic trauma, or female gender, we can see that low HRV, which is actually high fight or flight response of the nervous system, and and higher HRV, which is a parasympathetic nervous system response, can both increase vulnerability when nervous system is under-engaged or over-engaged in fighting the stress. So our next step was to contact all the authors from the papers. We've already done that, and we want their data in order to establish this U-shaped pattern. And we are waiting just 2 more weeks in order for all of them to come back from their vacations and give us the promised data. So let's really fast continue to the second project, exploring the association between multiple sclerosis, depression, and heart rate variability, which will be a prospective or observational study. Almost 3 million people are diagnosed with multiple sclerosis worldwide. And we know that MS is a chronic neurodegenerative disease, impacts the central nervous system and autonomic functions, including heart rate variability. And we also know that MS patients are diagnosed with very high percentages of depression. Almost 30% are diagnosed with depression, while in the regular population, only 7% are diagnosed with depression. And this has morbid outcomes because MS patients with depression have faster progression of disability, increased physical symptoms like fatigue and pain, and lower quality of life. And also, lower HRV is a predictor of both physical and psychological worse health outcomes, all of which can have serious implications for MS patients. So we have a problem, as low HRV is an autonomic dysregulation marker, and it is both lowered in MS patients and in depression. So we don't know why that happens. Is it because the deteriorating nervous system? Is it because of the depression, or a combination of both of them? So our aim is to determine the source of the reduced HRV to improve targeted treatments and strategies to better patient outcomes. The clinical question is, does heart rate variability differ between depressed population with multiple sclerosis compared to depressed controls? So relying on the PICO framework, the population will all be depressed, but half of them will have multiple sclerosis and half of them will just have depression, and the outcome will be HRV. Our hypothesis is that patients with MS and depression will exhibit lower HRV than those with just depression. And answering this question have both research and clinical implications that will help us guide targeted treatments to better patient outcomes. This research will be done in a collaboration with the Multiple Sclerosis Clinic in Bachki-Selinsky Hospital. So, to summarize, I have 2 projects. The first should be submitted by this November, and the second is planned to be submitted by September 2026. I want to conclude with the words of Gabor Mata, who is a physician. We may not be responsible for the world that created our minds, but we can take responsibility for the mind with which we created our world. Thank you for your attention.
Thank you for your presentation. It was really lovely. So your second project is about the low HRV and the depression, but did you, by any chance, while doing your research, find other problems that have the high HRV and the depression, and not MS, but something similar?
Many conditions have both depression and lower HRV. And actually, previous research have found found the brain regions that allocate this problem. However, if we study MS, we can find the exact mechanisms, because we think, like we hypothesize, that the deterioration of the nervous system in the brain because of MS, like it's specifically for this illness, can help us understand better the comorbidity between those two. So your question, yes, there are more comorbidities, but we chose MS because we can find something more. It's like a lab of the nature.
Hi, very nice presentation. My question would be about your first project, maybe a bit related to the second project. I was just wondering, what was your exclusion criteria? Because with heart rate variability, you can have heart failure patients with a high heart rate variability. I was wondering if you have excluded patients with heart failure and metabolic diseases, because these patients with a severe depression are more likely to be non-coherent to their regular medications. So it's more likely that they have such comorbidities. So did you exclude every patient with a cardiovascular comorbidity? And if you have excluded them, does that mean that you have included only depressed patients with just mild score of depression, or did you just include all severity of depression? So
it's a really good question, because it was one of the questions we had beforehand to what to exclude and what not. So we excluded only based on a psychiatric illness. So we excluded patients not just with prior depression, but all kinds of psychiatric illnesses. And we didn't exclude anything that is a physical problem. So we included those patients with heart failure. And that was in order to check it later. So when we looked at our analysis and the forest plots, we've seen we had 2 papers with patients with a heart problem that weren't in any way, they didn't make any changes in if we excluded them or included them. So actually what we thought is that it doesn't really matter for these results if you have or you don't have a physical problem. It's just the most important thing, whether your context of living and stress is affecting your psychology. Like, that's what we've seen in our results.
Thank you so much.
In your second project, you said it's going to be prospective, right?
Yeah.
So are you going to follow these patients?
We want to, yes. It depends on how many patients we can register. We think that because we are working in Paczki-Selinsky Hospital, they have approximately 200 patients. So I really hope that most of them will want to participate in our study, and we can continue looking at them at least 1 year.
Okay, and the other question, can HRV change over time, or is it something which is definite?
Well, HRV changes not just over time, it changes by almost like the minute, and that's the thing about HRV. So it can change even with menstrual cycle, with physical activity. But most importantly is in these papers, HRV is measured usually in the same context. Like people are sitting down, they're resting for a few minutes beforehand, they're not smoking, they're not eating anything that can change their nervous system. And then the HRV is measured in like 5 minutes, usually in 5 minutes time slots, and in very specific gear. So it makes it a bit better when we check that. So that's the way we do that.
Sorry for stopping here. My question would be that, for example, in the same setting, you check the HRV, but is it could it be different in the same setting 20 years from that point?
Yes. Older people, HRV is changing. Actually, we found out because we did some sub-analysis, and we didn't find anything really prominent, except that older people, their HRV changes dramatically, approximately when they are 70 and older. Okay, so. Sometimes, while we see in the younger population that lower HRV is in correlation to future depression, in older adults, we actually see the opposite, that higher HRV is correlated to higher future depression. So, yes, it changes, and we do take it into consideration, yes.
Just a quick technical question, because time is running. What is the physical measure of heart rate variability? Heart rate variability, I guess it's percentage. And what is the normal value, and what is the minimum maximum value you ever perform or experienced?
So usually RMSSD is measured in milliseconds. Okay, so it's not percentages. And it varies, it depends on women and or men and ages, but approximately, okay? So around 65 milliseconds, it's fine, it's okay, you are healthy. And most of the smartwatches today can show you that, and you can compare to your age and see that.
Thank you very much.
You're welcome.